hematological disease and cancer, we meet from time to time persons or patients that are refusing to take the conventional treatment. I'm inviting now Dr. Ellis Martin to give us an illustration of the therapies, the holistic therapies for people and patients that are refusing to take the conventional therapies.
Thank you very much. Good morning, everybody. It's daunting to speak after two such excellent speakers this morning, but I'll do my best and try and give you some insight with some anecdotes from my own personal practice about how to deal with patients who potentially resist conventional therapy. I think we've heard a lot this morning. I promise there'll be no talk of genes, no abbreviations, nothing that's threatening. It's too early and it's Sunday morning, so we're not going to do that. So hopefully this will be a little lighter as far as I'm concerned. It's very personal, and I'm sure that anybody who's practicing in the clinical sphere, and certainly people that have been exposed to patients with these kinds of problems or issues, certainly yourselves as advocates, caregivers, will have your own ideas and advice. And this is obviously something that's extremely personal and on a one-time basis per patient. But here we go. So I'll try just to be a little academic and talk about the extent of the problem. I'll spoil it and say we don't know. Identifying reasons for patients' reticence for being treated, and I think that this is, again, common sense. We'll have one or two examples of that. And then working with the patient and trying to find ways forward for individual patients. So, again, this is my experience. I do not believe that there's any medical literature that in any kind of scientific way addresses this problem. It might be an interesting project for somebody to take on. I think that it's very variable. My own personal impression, and it's really an impression, is that this tends to be a problem in patients who are newly diagnosed. We've mentioned during the weekend about the terrible shock to the system that getting a diagnosis like an MPN can cause for individuals. So I think that it stands to reason that perhaps there'll be a little bit of reticence at first. On the other hand, you could flip that on its head and say, no, well, people are now shocked into getting some form of treatment, so maybe the logic doesn't quite hold. But I'll give you some examples, and in my experience, it's often at the beginning when patients say, well, I'm not sure, I feel fine, my blood count, there's all this red on the chart, but I feel okay, so I'm not going to take anything. Again, my experience with sometimes older patients who have multiple comorbidities, multiple other illnesses, whose list of medications can sometimes fill half of a foolscap page. They're on 6 or 7 different medications, up to 14 or 15 pills a day, and now you come at them with another medication or two, which is going to be another 4 or 5 pills potentially a day. This is something that's off-putting for a lot of people. And obviously, I've seen this mentioned on people's slides during the weekend as well. Lack of information, poorly informed patients, this often tracks together with lower socioeconomic standing. This is clearly a problem. It's all about information, it's all about talking, it's all about communication, which is what this whole weekend has been about. And if you start off with the lack of either comprehensible or intellectually digestible information that you're giving to a patient, one obviously cannot expect him to blindly go ahead with your treatment plan and start swallowing more pills or taking injections. So poorly informed patients are liable to be not only poorly compliant patients, but also patients who are resistant to taking any treatment at all. So I think that, again, looking at it in a slightly broader context, people may be reticent to take medication, in my experience, because there's an unknown. They've been given a new diagnosis. They don't know much about the disease. They don't know what might happen. They don't know anything about the treatment, and they're not sure about how the treatment may affect their lives. And so the initial instinct is, well, let's leave things the way they are, especially as is in the case in a sizable proportion of patients with NPN. The patient is in fact asymptomatic, and we've diagnosed this disease on the basis of an abnormal blood count. It takes quite a lot to take prophylactic treatment your whole life. Most people don't forget to take a headache pill. when they suffer from migraine because they have a migraine, and so they're going to take their medication. But to remember to take your hydroxyurea, your aspirin, your combination, whatever it may be, for months, years, and decades, when really you haven't felt ill, hopefully, a day in your life, that's quite a chore and that's quite a mission. So I think that the unknown and not feeling ill is something that can put people off taking medication. Why should I be doing this? Prior beliefs, we've spoken quite a bit about that this morning. People come with a belief system, with an understanding of what illness is, of what treatment is, and that can be something, if it doesn't gel with our classical Western interpretation of disease and treatment, and I have one or two examples of that later on, there can be a clash, and that clash can result in patients not taking the treatment. Some people have a bent towards a naturalistic or a holistic approach. I think that was mentioned as well in the previous talks, certainly in the first talk. People who are more interested in curing or healing themselves or helping themselves by natural means, be it exercise, nutrition, supplements, additives, anything but something that comes off a doctor's pen or a doctor's computer. And again, that's a patient's choice, and it's their tendency, not as a patient, but as a human being. And this has to obviously be acknowledged, but it certainly can be one of the barriers to getting patients onto, let's call it, conventional, evidence-based type prescription medication. The poor understanding comes back at us over here. I think it's all about providing information. In the vast, vast, vast majority of patients, we will be able to get our message through, obviously in a humanistic and humane kind of way, but once we've provided the information and patients understand to the best of their ability what they stand to gain from treatment and what they stand to lose by not being treated. And then again, as I mentioned, the not the other pill complaint, not another pill complaint. I'm on so many medications, I'm already taking such a lot. This doesn't seem like a major problem compared to my poorly controlled diabetes or my hypertension that my doctor can't seem to get under control. So what if my platelet count is a little high? Why should I be taking all these extra medications? So identifying with the patient is, I think, one of the ways forward if we can try and use some techniques to connect with our patients and to encourage them in this way to take their medication. So I'm going to give you a couple of, not simplistic, but fairly simple concepts or thoughts that I have as a doctor who treats patients, and I'm sure that it's shared by other caregivers in the room as well. And just like to illustrate it with a little oddity, a story, Sunday morning. So I'll tell you a story about a boy who thought he was a turkey. I'm going to read it just to make sure that we stay on time. There was once a prince who lived with his father and mother, the king and the queen, in splendid fashion. He received the finest education and upbringing. To his parents' chagrin, one day the prince went through an identity crisis and came to the conclusion that he was really a turkey and not a human being. Initially, the king and the queen thought he was kidding. However, after he stopped joining them at the royal table and instead moved under the table and sat there naked and pecking at crumbs, they knew that serious trouble was afoot. Needless to say, the prince's strange behavior caused indescribable angst for his loving parents and intense embarrassment for the royal family at large. The king was ready to spare no expense for the person who could cure his son. The finest doctors and psychiatrists of the land came and tried to cure the prince, but to no avail. The king was at a loss until a gentle-looking wise man came to the palace. I hereby offer to cure the prince free of charge, declared the man. My only condition is that no one interferes with anything that I do. Intrigued and desperate, the king and queen readily agreed. The following day, the prince had company under the table. It was the wise man. "What are you doing here?" asked the turkey prince. "Why are you here?" countered the man. "I'm a turkey," responded the prince emphatically. "Well, I'm also a turkey," the man replied. With that, he began to gobble like a turkey and peck at crumbs on the floor. The prince was convinced. A few days passed in this fashion. One morning, the wise man signaled to the king to bring him a shirt. He said to the prince, "I don't see any reason a turkey can't wear a shirt." The prince thought about it and agreed, and soon the two of them were wearing shirts. Soon the wise man asked to be brought a pair of pants. He said to the prince, "Is it forbidden for turkeys to wear pants?" "Certainly not." The prince thought it over and agreed, and soon the two of them were wearing pants. So the process continued. Shortly after, The wise man convinced the turkey prince that it was not forbidden for turkeys to eat human food, which was surely tastier, then came sitting at the table and enjoying human conversation. Within a short time, the turkey prince, although still maintaining that he was a turkey, began conducting himself exactly like a regular person. So it's a simple parable, but I think it contains a message. And the message is that if we, so-called the wise man who's coming to cure the so-called turkey prince, and here the metaphor will end, one has to speak a common language and one has to act in a common way. That is not to say that physicians or caregivers should take on different roles and become medical clowns when needed, but certainly they should consider doing that and acting in a way that is commensurate and congruent with the patient's understanding, beliefs, background. And I think a lot of us in this very sort of cosmopolitan society that we live in are exposed to people from many, many different backgrounds. I know certainly I am. Again, one or two examples will come up. And it's very difficult to maintain your facade of respectability, of white coat and tie sort of behavior when you're dealing with people from a completely different background. I'm not saying that we need to get naked under the table, but I think you get the idea. So, in a more didactic kind of approach, things that have been written about in literature, and there's some beautiful examples of this in the medical literature. Francis Peabody said that the secret of care of the patient is caring for the patient. And clearly, if we as physicians, caregivers, associates of patients encounter people who are resistant to treatment, who we know are engaging in self-damaging behavior, for whatever the reason may be, clearly our first obligation is to care for the patient, not necessarily for the disease, or to care for the person, not necessarily to care for the disease. The disease is occurring in a context, in a human context, and it's sort of back to the turkey story. There's no point in bashing your head against the patient's head or against the wall as a caregiver. That's not going to get the patient to comply or to be any more agreeable to move forward with what we perceive as being the correct treatment course for a particular patient. So I think, as physicians, our first mission is to care for people, to care about people, and then to try and treat disease in some way. And building trust is certainly the first step towards this. I'm speaking again from my perspective. This takes a lot of time, it takes a lot of effort, it takes a lot of patience. It requires doctors to minimize their ego, to make space for the conversation in the room. We all are familiar with physicians and caregivers who will have absolutely no time or no interest in continuing this kind of relationship with the patient. That's a pity. I don't think that has anything to do with having patient advocate groups or not having patient advocate groups. It has to do with there being caring doctors out there and doctors who see healing and looking after people as their mission. If that is not present, then there's not going to be success in that small fraction of patients who are resistant and not compliant with the doctor's orders, so to speak. The Balint groups, I think perhaps those from the UK may be familiar with these. This is a very important addition to modern medicine. A well-known psychoanalyst who moved to Britain, I think in about the 40s or 50s, by the name of Michael Balint, started this entire culture for general practitioners, really, to deal with patients' anxiety and concerns about illness. It was at the time when medicine was becoming modernized, Western medicine was becoming modernized in the last century. And after his passing, these groups continued to be active around the world. There are a number of them in Israel, which is interesting since it's not exactly the same culture as the British culture, but they do exist for general practitioners where I work. They're called Balint groups. And one of Balint's famous quotations was, "Sometimes the doctor is the drug." Clearly, doctors do not get into patients' blood vessels and decrease platelet count or decrease hematocrit or shrink the spleen. But again, I think you get the idea. This metaphor as the doctor as drug can be extremely, extremely powerful. It's not something that necessarily develops at the first consultation or early on in the relationship, but we're dealing with chronic illnesses here that have ups and downs, that have complications, that have transformations, and eventually the doctor becomes indispensable. And again, this is not an attempt to pump up anyone's ego in the caregiving community, but it's a fact, and it's a fact I think that we all acknowledge. It comes with tremendous responsibility, and in today's technological age, it also comes with not inconsiderable burden of instant electronic access, irrespective of where you are on the globe and what time it happens to be where you are locally relative to where your patient may be. And sometimes it's nighttime here and daytime there, and yet you are as important to the patient, and perhaps as important to the patient's successful journey through their illness as the medications they are taking. So I think this is something that caregivers need to be cognizant of as well. We've spoken a lot about proxies, caregivers, part of the patient's treated community. They will be the ones to choose who those individuals will be, but engaging such individuals is critical for successful engagement of the patient, especially patients who are resistant at first to finding their ways forward. So some brief examples, and I'll give you 4 of them and expand perhaps on one. So I have a woman who's 78 years old. She has ET, and she was one of these people who said, no more poison, no poisons for me. She's actually healthy apart from her ET. She doesn't take other medications or perhaps 1 or 2 sort of vitamin D supplement, but she wasn't interested in being poisoned at all. She was quite a woman with quite a strong sense of self, independent, lived alone. She is a widow. She lives alone. She looks after herself entirely, and she wasn't interested in taking hydroxyurea, which is what I had prescribed for her. So she actually engaged quite actively with the activities of our local MPN patient group. And for her, and I think this was one of the things that Stefan mentioned earlier, it was all about empowerment. It was all about her taking control of the situation. And it took about 6 to 8 months. She clearly had an indication for hydroxyurea. It would have been a disaster, I think, if she'd have had a catastrophic thrombotic event during that period of time. But she came to the realization that this was a drug that she shouldn't fight off as being another poison, but she should embrace as something that could help her achieve better health. Again, asymptomatic woman, we're just talking about an abnormality that was detected on her blood count. She analyzed, and I would dare say overanalyzed her situation. She's extremely well informed. She was very concerned that she had early PMF. She'd been through all those long lists of criteria that you saw on Friday from the WHO, and she's really a smart woman and really got incredibly involved in her diagnosis from an intellectual point of view. I think in a way to try and intellectualize the process, and in that way enable her to deal with it. So she needed the empowerment. She needed to make the decision. She needed to take control. She needed to say, I've been speaking to people on the forum. I'm now going to start hydroxyurea because I'm ready and I want it, and I have decided that this drug is going to be helpful to me. And she's tolerated it absolutely fine, and she's completely happy with her decision. And now she's becoming an advocate for other patients in the MPN group to start treatment when they may not feel they're ready for treatment. How that will work out, I'm not sure. But clearly, this was her way forward. Without being judgmental in any way, as a physician, when one looks at the patient as a whole, for good or for bad, this woman clearly has some very faint narcissistic tendencies. There are a number of personality types that we learn about in psychiatry, and when one type dominates, that's when you have potential for a personality disorder. I think people that have narcissistic tendencies, and they're all around us, we all do to some extent, it's part of our natural makeup, but when that becomes a little more dominant, those are the people that will say, you're not going to be telling me what to do, I'm the one who's going to decide when it's time. In my experience, that is a tendency that is insurmountable, and it's not worthwhile trying to overcome that in a confrontational manner. And those are the people that when they eventually get to that decision, it'll be the right decision for them, and they'll move on. That's my first example. A 64-year-old woman, also with ET, is a fitness fanatic. I didn't bring a picture of her because I didn't get her permission, but she really is in incredibly good physical shape. She looks and acts a lot healthier than most of her caregivers, including this one. And she, by definition, needs therapy. But she says, listen, I'm completely fit. She always comes, I'm not sure if it's subconscious or conscious, but she always comes to her clinic appointments dressed in her gym equipment. She's either been or going to the gym. I'm not sure if that's a statement, if it's something she's conscious of, but I'm certainly conscious of it. She always looks disgustingly healthy when I see her. So what I've done with her is just have her come in more often. I think Yvonne mentioned sometimes people get a long rope, 4 to 6 month visits. This woman could easily come and see me twice a year, but I have her come and see me 4 times a year because she's kind of off protocol. Again, I hope and pray that nothing bad happens to her because her lawyers would have a good time of it if it did. But clearly, from my point of view, everything is documented and our conversations are documented and her requests are documented and her choice is documented and my advice is documented. That's sort of just to put that on the side. Whether that will be helpful to me or not, I'm not sure. But in terms of her, I just keep a closer eye on her, and I keep reinforcing what the guidelines are recommending. We spoke a bit about guidelines yesterday afternoon. There are guidelines. They are not treatment protocols. They are not law, the law of the land, but they are guidelines, and this patient is certainly aware of the guideline recommended treatment for her. This is her choice, and I as her physician, care for her. And I do not think that she is being irresponsible in her decision. I think she is healthy. I think that her coronary arteries and her carotid arteries are probably pretty clean. And I doubt that she's going to get into serious thrombotic trouble because she has an elevated platelet count. I have a 54-year-old patient with polycythemia vera and moderate intellectual impairment. We heard about sometimes the foibles associated with venesection and phlebotomy, and he will have none of being phlebotomized. The needles scare him. It's very hard to get him to have blood draws. So we've tried all sorts of things with him over the past couple of years that he's been in the clinic. We've engaged his family. He's an older person with intellectual impairment, so you can imagine that this has not been easy for the family, and now to have PV on top of it. So the family came in. We tried relaxing him with music that he likes to listen to, and we try to get from the family what is liable to be helpful for him. We have medical clowns that come around our outpatient department for adult medical clowns. We had them come in and try and work with him, but to no avail. This was not going to work at all. So again, off protocol. This gentleman, he needs treatment. He needs his hematocrit controlled. So he's a little young. He doesn't fit the guideline for this, but he's on hydroxyurea, and that he's quite happy to take. So does anybody know what hujama is? No? So I have a 56-year-old man with polycythemia vera who said that he would like to be treated with hujama. And he's being treated with hujama. Hujama is an Arab word which means sucking. You can Wikipedia this in 2 minutes, and you will see that this is an ancient process that has been in place since the Middle Ages, since the time of Avicenna. In those years, as in the Western world as well, bloodletting was considered to be, even in Hippocrates' times, to be an essential way of maintaining health. So this man I saw about 4 or 5 years ago, diagnosed polycythemia vera, recommended phlebotomy and aspirin. He took the aspirin and disappeared. He came back to me about 6 months ago with abdominal pain, which was his spleen that had enlarged, and a normal blood count. And I said, well, this is amazing. What's going on? Has he developed myelofibrosis already? At which point I said to him, well, I'm very sorry. We should have perhaps reached out to you. I'm not sure how. We should have noticed you didn't come back to a clinic appointment. That happens. Patients that don't come back, we try and have a way in place of dealing with that. But this gentleman fell through the cracks, or so we thought. But he said, no, I had no intention of coming back because according to my beliefs, bloodletting using this process of hijama should be done. It's done at particular times of the month. It's done during particular months of the year. And this process is able to remove bad spirits from the blood. But it removes blood. It is a form of phlebotomy. And here we see this the process being done. And these are photographs that he provided for me. By the way, he's absolutely functional. He's a high school sports teacher. There's nothing odd about him as an individual. This is something that is congruent with his beliefs and his lifestyle. You can see the equipment that is used. This is performed by someone who practices this in the community. It's not a medical practitioner. There's scarification of the skin that occurs, heating of the skin, scarification of the skin. These cups are applied, and you saw in the previous, in this picture over here, that there's suction that's applied to the cups, and they tend to fill up with about 20 to 50 milliliters of blood, depending on the amount of the vacuum that's applied. It can get a little drastic. This is him doing it on the sides of his leg, and this is what his back looks like after a typical session. So when he re-presented to me 4 or 5 years later, I discussed with him the potential negative effects of this, which I'm not really sure what they are, but I think that common sense would tell me that perhaps infection, scarring of the skin, trauma to the skin would be a negative effect of this kind of treatment. This did not faze him at all. He said that lots of people that he knows undergo this for spiritual reasons, and he was following his own hematocrit and really doing quite a good job. So he's continuing to do his hijama treatments. The deal with him, so to speak, is that he will come back for monitoring in the clinic in a more conventional kind of setting, and we'll have discussions about what to do if his hematocrit is not well controlled. My suspicion is that he'll just have more hijama done, and he won't have me sticking needles in his vein. Thank you very much.
Thank you very much, Dr. Martin. And if someone has some question in the audience, please raise them around.
Hi, thanks, Martin, for this inspiring talk. I think I wanted to know if you can estimate in percentage, what is the percentage or number of patients that are refusing to take treatment? I can tell you that in my experience for 20 years from CML, from the 500 patients that we have been looking after, I think we didn't have more than 5 cases. And in Israel also, you didn't mention, but most of them were due to their Jewish Orthodox who believed that they will be healed by God. And they refused to take the TKIs until their condition got worse, and then they went to the Orthodox doctor who treats them usually, and then they listened when the situation got worse and the CML was progressing. But what is the percentage of patients that you think have this issue?
Thank you, Giora. I did mention that on one of the slides. The exact extent of this phenomenon, as far as I know, is unknown. And I can just tell you from my own personal experience and the experience perhaps of some of my colleagues in the department in which I work, it's way below 1%. These are unusual patients, and these are extreme examples. And I can perhaps think of another 3 or 4 examples that I could have brought. So I've sort of dealt you my entire deck of patients who won't have treatment. Clearly, there must be more out there that we don't know about. By definition, again, we have people who join MPN forums and who participate in MPN forums. That's a select group of people who are voting with their feet or with their computer pad. This gentleman with the hijama, he just disappeared. He was off my radar for 4 years. I forgot about him. I think I met him perhaps once. I would have had no idea that he existed if he didn't come back to see me. So the true number, I think, is unknown. But it's not something that we deal with every day, and it's not a major issue, certainly not in my practice. It's a minor issue.
Please, John.
Not a question. Relax, everybody. I'd just like to congratulate all of our speakers this morning. I think this has been a really exemplary session in the sense that the speakers came at their subjects with very, very different approaches and styles, and all of which worked extremely well, I think. And I'd just like to congratulate them for that. Unfortunately, Martin, forever now you're going to be associated in my mind with an image of a naked man under a table pecking at food on the floor. I'm sorry, but you did that.
Michel, Just to follow up what John was saying, I really appreciated both Dr. Ellis and Yvonne, that you talked about being in solidarity with your patients. And we know from experience talking to patients that they don't always feel that from their physicians. And to your point, probably go and they like ghost from their doctors and don't seek medical care. And I think it's really admirable that you guys are so loving and caring towards the people that are coming to you for advice. And we hope that more doctors and nurses take that approach because it's really admirable.
Any other questions? Okay, thank you, Dr. Martin. We're off time now, so we have a coffee break until 11, and I would like just to ask you to fulfill the feedback forms and to give it back to Lydia and Vanya. Thank you.